And just stop me if you have a question while I'm talking. I don't care. I don't think my slides will take the full time, and I have 4 cases with some multiple choice questions at the end. So you can spare yourselves from those if you ask a lot of questions. All right. So what I wanted to talk about today was essentially shock and severe heart failure. And I wanted you guys to kind of be comfortable with, evaluating patients to see if they have heart failure and deciding what is the severity of the heart failure if you think they have it. I also wanted you guys to be comfortable with choosing initial therapies. Most of the time this is kind of done beforehand or in the ER, but I think as we separate as a service, you might be, called down to the ER to help them out to make some of these decisions. And it's kind of important to not feel kind of flat-footed and to have a plan of what you're going to do. And lastly, sort of, once we have these patients and we're flying along up there on 5 Southeast, where's the ship going? What are we doing with these patients, and how can we get them to be less ill and at least out to the floor and hopefully home or to some form of definitive care? All right. So let's start out very basic. What is heart failure? Anyone?
Failure of the inability to pump blood adequately. I was just saying,
Sure.
the heart can't meet the oxygen's metabolic demands in blood supply.
Yes. So the heart is not meeting the metabolic demands of the body. Usually we consider this to be some normal metabolic demand, like sitting at a table or walking down the hall. But technically, by that definition, people who don't train for marathons and try to do them also have heart failure because they're not meeting their metabolic demands. So just keep that in mind. So this is the National Library of Medicine definition. Complex clinical syndrome of symptoms and signs that suggest impairment of the heart as a pump supporting circulation. So you guys got it. And then as we go through here, and I think this is very helpful for rounds and just thinking about patients in general, is to sort of put patients into various bins of what kind of heart failure they have. The treatment for various kinds of heart failure is completely different depending on what type, what is the etiology, and so forth. So one of the first distinctions you'll want to make is is the heart failure due to a systolic dysfunction or due to diastolic dysfunction? So as you might imagine, systolic dysfunction is essentially sort of insufficient cardiac output and insufficient stroke volume to maintain cardiac output. And it's usually characterized by low flow through the bodies, kind of how we think about it. Whereas diastolic dysfunction usually has a preserved cardiac output until the very late stages, but is characterized by really high filling pressures. So these are your kind of, the classic kind of old women with stiff hearts who can't breathe because their wedge pressure is really high because it has to be really high in order to fill their heart up. They tend to pump plenty of blood out in the end. They're not suffering from hypotension or anything, but what they are suffering from is really high wedge pressures, and their lungs are suffering because of those high wedge pressures. Now, there's, it's kind of a spectrum, and lastly here I'd point out that many patients with severe systolic heart failure have very dilated hearts, and they're at sort of their maximum elastance, and they can't really accommodate more blood without having obligatorily high pressures. So we also see that there as well. But do think, does this patient have systolic failure or diastolic failure? Most of what we're going to see in the CCU is systolic failure. But it's important to think about. Next, you get to pick a side. It could be one, the other, or both. So you want to think about whether the patient seems to have more left-sided symptoms or more right-sided symptoms, okay? And left-sided symptoms are, patients usually have a high wedge pressure, and blood is backing up into the chamber in front of it, which in this case is the lungs. So it's characterized by hypoxia or lung congestion. And you also have to remember this goes all the way back through the circulatory system, all the way to the venous side. So left heart failure alone can back up all the way back into the inferior vena cava, superior vena cava, right atrium. But the classic thing is to think of left heart failure as causing high wedge pressures again, and poor forward flow as well. Characteristic right-sided symptoms are some of the left-sided symptoms, but we get these very high pressures on the right side, Technically, if they just have right-sided heart failure, you could probably measure a wedge pressure and it would be normal, okay? Unless they're just retaining a lot of water, in which case it might be slightly elevated. They have a very small difference between their right atrial pressure and their PA mean pressure, which is to say that the right heart is doing very little work, right? So the right heart is supposed to pressurize blood and send it through the lungs, but if it can't really pressurize blood, and you have a Swan in, you can see that because those, the right atrial pressure and the PA mean pressure are getting closer and closer together. And can anyone think of a congenital abnormality or a congenital surgery, I should say, that is like complete right heart failure? What's that? I think you said it. What's that? Yeah, so in a septal defect, whichever chamber has the higher pressure is going to circulate blood into the one with the lower chamber. I'm thinking of a surgery that we do, like you guys know about Fontan surgery? So basically that's a total bypass. It's like you hook up the IVC and SVC right to the pulmonary artery, essentially. And so that's like complete right heart failure. In that case, the PA mean pressure is exactly the same as the right atrial pressure, right? So that would be an example of a complete right heart failure. And patients with chronic right heart failure especially tend to have a lot of ascites. They tend to have very tenuous renal function because they have renal venous congestion, and they can't really get a gradient over their glomerulus to filter blood out, okay? So we've talked about systolic, diastolic, left, right. And you're also going to think about, yes?
Explain a little more why they have tenuous renal function?
So, I mean, this is an observation.
Okay.
This is not like
Physiological.
something I can describe to you a large series of patients where this is true. But essentially, across your kidney, you want blood to flow downhill across the kidney, and the more downhill it can flow, the more filtering it can do.
Okay.
And in right-sided heart failure, the venous pressures kind of come up, and you can't really create much of a gradient, is the thought. That's somewhat anecdotal, but that seems to be how these patients behave a lot of the times. And when you're having a lot of problems with renal function, if you look at the right heart, it's usually not working very well. Okay. All right. So we've talked about systolic, diastolic. We've talked about some of the left or right. And then you want to think about what is the cause of heart failure, okay? And I'm not going to go into detail here, but I always think in my mind of 4 or 5 things when I think of the causes. So myocardial problems, so poor perfusion or stiffening of the heart. One example would be poor blood flow in the case of like a myocardial infarction. A restrictive myocardial disease might be something like amyloidosis, where something's making the myocardium sick, or radiation exposure. Electrical problems of the heart, so any type of arrhythmias. Valvular heart disease, so here blood is not going through our one-way pipe in just one direction, it's going backwards at some point, which is abnormal. Sort of extrinsic things to the heart, to the pericardium itself, like pulmonary embolism or tamponade, something acting on the heart to cause it to not function properly. Okay. And then lastly, another extrinsic thing that we can sometimes see or that can exacerbate existing left or right heart disease is pulmonary hypertension, which is a long-term response to abnormal physiology. And in pulmonary hypertension, we don't get as much flow across from the right side to the left side, and it can result in right heart failure independently of the left. It can also result in underfilling of the left ventricle and poor cardiac output, which these patients all suffer from. Who here has seen someone with chronic idiopathic pulmonary hypertension? They're sick, right? They have decreased cardiac output, but it's not really because their left heart doesn't work. It's because their left heart is not getting any blood. And it's because their right heart is failing due to the lungs. So this would be another example of something extrinsic. The acute example of this would be like a pulmonary embolism, right? Kind of the same physiology. One just occurs over a much longer period of time than the other. Okay. So So we can kind of use anything that you can name, you can call it a taxonomy. It's really nice to kind of organize your thoughts around these things to be sure that you get all the pathology handled that you're thinking about in your patient. So again, you can just kind of go through here and in your mind create this kind of taxonomy. And then as you get more experience, you'll kind of come to understand what treatments go along with which of these taxonomies and which of these entities, okay? All right, so now we have some sort of nomenclature for working with heart failure. Now we need to decide how severe is the heart failure, okay? So what we want to focus on here is the history in the exam, okay? You're going to get 90% of the information you need to start, change, stop therapies based on these things, okay? Secondly, you're going to worry about lab findings, echo findings, invasive hemodynamics, and so forth, okay? Sometimes those become important to kind of flesh out your taxonomy and figure out what is going on. But for 90% of what you're going to encounter, you should be able to make a lot of your decisions based on the first two things. And it's the ICU, the people's got lines in, there's people everywhere, there's a lot of excitement, but sometimes people don't talk to the patients and figure out, yeah, I've been taking 400 milligrams of furosemide 4 times a day for the last week and a half, and maybe that's why they're hypotensive. So sometimes it's pretty easy to figure these things out just based on the history. So if we're trying to figure out whether the patient has shock and how severe, we should probably first know, what is shock? Do you guys have a definition in your heads of what is shock? Cardiogenic shock?
Damage to the heart and you can't pump blood adequately anymore.
Sure. So that's definitely part of it. We kind of require one other little tidbit, though. Because there's a lot of people with hearts that don't work very well.
Inability to perfuse end organs.
Yeah, so some evidence of end organ dysfunction, okay? And I want to kind of encourage you guys to have a very low bar for saying someone has end organ dysfunction, okay? We don't need a bunch of labs, we don't need a Swan, we don't need an echo. If the patient has some of these features here, you're done, okay? You already know that they have lack of perfusion if they're falling, if they're pre-syncopal, syncopal, if they've had VT at another hospital or something before they got to you. Any of these things would sort of define that state before you've ever drawn blood or done anything, okay? So, on Monday I saw a patient in my clinic who said the room was spinning and he couldn't sit up straight. He wanted to lay down on the exam table. I sent him to the ER. I started dobutamine. You don't need to, I knew he had a low EF, which, is helpful to begin with, but, you don't need to figure out how low his EF is if you're in that situation, okay? So when you guys get called to the ER, start talking to the patient. I promise you'll figure out what's wrong with them and you'll choose the right therapy based on your discussion alone in most cases, okay? All right. And how good is the exam? Okay, we're going to spend a lot of time looking at people's neck veins and so forth. And for the most part, I think this is a useful exercise. But your exam can miss things, okay? And that's what you have to be careful with the exam. So, for example, the combination of RALS, edema, and elevated JVP on physical exam, they kind of scored these patients in this little study they did. And then they wedged everyone to see how dysfunctional their left heart was. And you can see that amongst patients with a high wedge, the exam caught 53% of them. Viewed another way, you missed almost half of them who had a bona fide problem that you did not detect. However, when those things were present, most of those patients had abnormal findings, okay? So you want to be careful that when you don't find what you're looking for with exams, that you're not getting tricked and that you're not just missing what you're looking for. That's very common with physical exams. It's very common with many of our diagnostic tests that the absence of diagnosis doesn't mean that you should feel good about it if you have a strong clinical suspicion. Okay. All right. Now how many of you have taken care of heart failure patients in the past? Everybody? Okay. You probably know this, but if you do get to the labs, if there's some question of how severe things are, you can use these even as you go along to figure out whether you're doing a good job or a bad job. A low sodium is bad, generally. And does anyone know why a low sodium is bad? Does anyone know what's happening in the body that creates a low sodium? You're thinking they're full of water. Why there's... Yeah, and why is it, what is diluting the sodium in the body? Yeah, fluid, and basically your anti-diuretic hormone system kind of takes over at some point and says, well, I don't care what's going on. If the kidneys aren't getting perfused, we're going to hang on to water, okay? So it just starts doing that, more so than it hangs on to sodium, and you start dropping your sodium, okay? Creatinine increasing is pretty self-evident, I think. Don't be fooled, though. There are some patients with really severe heart failure and heart failure cachexia who can have low muscle mass, who may have a very different creatinine clearance or glomerular filtration rate than their creatinine would suggest. So keep that in mind. BNP increasing is obviously increased stretch in the heart. It can also be exacerbated by increasing creatinine too, right? So it leaves the body through the kidneys, and pro-BNP is even more sensitive than regular BNP, but they're both affected by renal clearance. So sometimes you can just be fooled by renal function alone, but it's unusual that in our severe heart failure patients the renal function is normal, and that you get fooled in that respect.
Which BNP do you use there?
We use a BNP and not the pro-BNP. I think the one we use is better for its reason to some degree. So. You can always look at the other organs, as you suggested. You have to have some end organ dysfunction. Something we commonly see is elevated transaminases, elevated bili, and so forth. We don't measure very often here, but patient has abdominal pain. It's probably worth getting an amylase, a lipase. We not uncommonly see pancreatitis occurring when you look for it. We just don't look for it very often here for whatever reason. And lastly, the saturation of mixed venous blood. So who has ever looked at the saturation of mixed venous blood to figure out what's going on with their heart failure patient? Yeah. So I think it's a fine measure, but don't overdo it, okay? Like, it's dependent upon a lot of things. If the patient is stressed out, if they just went for a walk, it can be really low. It's probably really low in a lot of our patients who are just walking around the world. We're not measuring it, so don't put too much stock in that SVO2. But if it's dropping and so forth, use it as a trend, but don't rely on it completely. All right. Do you guys want to excavate your lunch here? Should I stop for a moment, or do you want me to just keep going? I'll let you guys get your lunch. I'll be all right. I have diet spray. All right. Is that all the food? Okay. So if you've gone by the history, you've gone by your exam, you've gotten your labs and things are still confusing, what would you do next? So you have two options. I'm kind of strongly suggesting one here. So good, very good. So you can put in a PA catheter. I think the other thing that can sometimes be very reasonable to do is just start treating them. What do you think is going on? And if you're wrong, you fix it, okay? Sometimes that can be a dangerous proposition, but many of our patients are volume overloaded, right, who have heart failure. It's rare that you put in a Swan and find out they're dry. I mean, that happens like 5% of the time or something. So you can usually make some assumption that their cardiac output could be improved and that their volume status could be reduced, okay? But what do you guys hear about Swans? Are Swans good for people? Are they bad for people? What do you guys think?
They're bad for people.
carry, they're bad for people. Why?
I think that wasn't there a study that showed that it was like a meta-analysis that showed that people with PA catheters had a worse outcome,
Yes.
had increased mortality.
Yeah, I think that was in medical ICUs, or largely populated by patients in medical ICUs, which is fine.
There's many heart failure patients.
They're allowed to do poorly as well.
Or even
Right.
the numbers that they generate don't always exactly correlate with. I don't remember what the article said.
Sure.
I
Right.
can't speak for
So there's this whole literature in medical ICUs that shows that patients have more infections, that they don't do better. So this is considered bad. There's only one really good heart failure study that we have. It's called the ESCAPE trial. And in the ESCAPE trial, they measured kind of a funny thing, which was days well. And they measured it cumulatively, but there are two lines here. I don't know if you guys can see that. There's a little gray line that peeks out there. So this is in the, I'm not even sure which is which. Here we go. So clinical assessment's gray, and black is the PA group. So they're identical, okay? There's no benefit to Swan-Ganz catheterization in these patients. But let's ask ourselves for a moment, who are these patients? So I'll just read this. The target patient was sufficiently ill with advanced heart failure to make use of the PA catheter reasonable, but also sufficiently stable to make crossover to PAC for urgent management unlikely. So what does that mean? What are we doing in the CCU usually? We're kind of there to do urgent management, right? So, these patients couldn't have been on inotropes for 6 months. They couldn't have been hospitalized for some amount of time prior to the study. So this is actually a study examining whether putting PA catheters in kind of moderately ill heart failure patients made any difference, not the severely ill patients that we are more likely to be encountering. And that's not to say that all of our patients need a Swan, but it means you have to think about it. And what are you gonna think about before you get a Swan? In my mind, you really need to think about what data do I need from the Swan that I don't have already. And there is a distinct set of data that can only be obtained from a Swan. Okay, so we can only assess right heart failure well, knowing what is the CVP at the same time we know the PA mean pressure, like we talked about. We cannot calculate pulmonary vascular resistance without a Swan. We can only get very accurate measures of pulmonary pressures, especially when the patient's on a ventilator, for example, if we have a Swan. We can only get a wedge pressure with a Swan. You can get a LVEDP with a left heart catheterization, but you're not going to know what to compare it to, and you can't get the rest of the numbers. And it's nice to have the systemic vascular resistance, which you can get without a Swan. You can get with just a CVP, but you need to have some way of estimating cardiac output to estimate that resistance if you're trying to differentiate, sepsis from hypovolemia, for example, or cardiogenic shock. So every time you think you might need a Swan, please say that, but also be ready to answer sort of what are we going to do with this information. I would also point out that all the studies of Swan-Ganz catheterization, there's no protocol that anyone followed with what to do with the data or how long to keep it in. So, if you don't have a plan, it shouldn't be too surprising that it didn't look like a very good treatment, because everyone was probably doing completely different things with the information. Okay, any questions about that? All right, so after you've gone through all that, one way of thinking about these severe heart failure patients is to kind of put them into this 2x2 table, and you're just trying to decide whether their volume is either increased or decreased, okay? And whether their perfusion is adequate, which means they're warm in the colloquialisms of Lynn Warner Stevenson, who kind of invented this categorization, or they're cool, meaning they have, they're in shock, or they have signs of hypoperfusion, okay? So these are kind of you're not going to see a whole lot of these guys who are just congested in the CCU, right? Those patients are on cards B, they're on cards A, they're getting diuresed. They diurese just fine. Their kidneys do okay while they're getting diuresed in general. These are more of the patients who we are most likely to see, are these kind of cold patients who are also usually volume overloaded, who have a very low cardiac output and who don't diurese easily without inotropic support or some other form of support of their cardiac output. Okay? And then lastly, in the heart failure world, these would kind of be your over-diuresed patients who probably have a lot of poor function to begin with. Okay, so this is hypovolemic shock on top of cardiogenic insufficiency, very bad, but usually corrected pretty easily. And if you're warm and you don't have enough volume, you're probably a heart failure patient who is septic or something else is going on, okay?
Sepsis could be in the bottom right as well, right? You could have somebody who's not perfused and hypovolemia distributed.
Yes, you are correct. In the Lindmore-Stevenson world, you feel people's extremities and you try to make decisions about what's going on with their perfusion based on that. So you could get fooled if someone's septic and hot and febrile and vasodilated, right? So, but I agree, their perfusion is not good, but their skin is warm. So, all right. So, so what are we going to do with these patients, okay? What do you guys think is sort of a first-line therapy for some of our, cool, wet patients? What do you want to do with them? You want to diurese? Yeah. And put them on dobutamine. Great. So we'll hopefully reinforce that idea as we go through here. But you basically want to augment cardiac output usually first. Right, so I disagree with you a little bit and say you probably just want to start giving them some dobutamine if you feel like they're not perfusing well, because you're probably not going to get too far with diuresis if they're not perfusing their kidneys. And once that's going with one of these things, get a big dose of diuretics, and then after that's, figure out secondary things. Is the patient still ischemic for some reason? Do they have a valve abnormality you can correct? Is their arrhythmia under control? Okay. So let's think a little bit about some of the tools we have in our toolbox. And I don't have a lot of data to show you for these things because there's not really a lot of data to be had, especially for ICU kind of patients. But what we can really just try to do is describe how best to use the tools we have to accomplish the goals for these patients that we have. So in general, diuretics, I'm not going to go into great detail here. Did you guys talk about the diuretic protocol already? Are you aware of a diuretic protocol that we have? Okay, we can circulate that, but it is essentially designed to get you to use a large dose of diuretics up front and to use constant infusion of diuretics to keep the patients peeing, okay? What we found is that basically a lot of our patients are massively volume overloaded and doing boluses just doesn't really work particularly well, and boluses tend to get held and started and stopped, and they also seem in our experience to cause some hypotension as you have these big kind of fluid shifts and reequilibrations. Okay? So I'm not going to say much more about diuretics other than keep the patient peeing at all costs and don't underdose them, okay? I always tell people there's 2 doses of furosemide, 100 and 200. I never want to come in and hear like, yeah, we gave him 20 of furosemide and then we gave him 30 and then, double the dose if it doesn't work and give big doses because usually the biggest thing you can cause a problem with is hypotension, sometimes renal insufficiency, but we can always give fluid back if we have to or let them reequilibrate. But if we let them cook along with increased intravascular volume, that causes all of our problems and we're not helping anything. And what does diuresis do? Meaning, what physiologic thing are we improving by giving diuretics? Is anyone?
Decreasing gut edema.
Yeah, so we're decreasing edema, which is uncomfortable for the patient and causes other problems. How about in the heart itself or lungs? I'll give you the lungs too. Yeah, so you're going to decrease preload. But what happens when you decrease preload? What happens to stroke volume? So is that good? It's not great. What people think happens is that as you reduce the preload, you decrease the size of the ventricle. And do you guys know about functional mitral regurgitation? That is to say, there's nothing really wrong with the mitral valve itself, but it's getting distorted and stretched out, and it's tethered to the end of the heart via the cords. And that by diuresing people, you actually decrease a lot of mitral regurgitation, and in doing so, you increase stroke volume. There's also a thought that you reduce kind of subclinical ischemia and also improve contractility, eventually kind of increasing contractility and increasing stroke volume as a result of all that. So it's not just the, I had a hard time with this for a while as well, but it's not just the preload that you're altering a lot of other cardiac physiology beyond just the Frank-Starling curve. Okay? All right. And can we all agree that cardiac output is stroke volume times heart rate? So if you have a patient who you think has low cardiac volume, all holds are off. Okay, you can do whatever you want to increase stroke volume or increase heart rate to improve their cardiac output. Okay. And let's go through some of the things. Before we get into this, we're going to do some. I think you guys have seen these graphs this week already. I heard some hemodynamics were done, so no one freak out. So what is this? Since I think you guys have already seen it. Starling curve. All right. So, and as radial pressure increases, and that's how they did the experiment, right? It wasn't radial volume, it was radial pressure that they were altering. Cardiac output goes up until you get to a point. Now, one point, everyone thinks that this curve goes up and then comes down. It does not. Okay. So being on the Starling curve, you're always kind of on the curve. It's hard to fall off the end, per se, but you guys all know probably you can be on different curves, right? So for a different amount, or for the same amount of radial pressure, you could have a completely different cardiac output, okay? So what happened here? Let's say where this arrow is, and we haven't changed radial pressure, what would we have had to have done in all likelihood? Yeah, we could have increased heart rate. We could have increased contractility. We could have repaired mitral regurgitation. We could have done anything that will increase stroke volume and get you at a higher
Why do you say
contractility.
that doesn't do that? Yeah.
It just doesn't. I don't know how else to.
Okay.
It doesn't. The heart is really big and dilated, and it is trying to preserve stroke volume at all costs. And as you go up, now as you go up here, you can do other things outside of this whole dog lab. You can cause more ischemia. You can cause more mitral regurgitation and then go off the curve, I suppose. But in the classical sort of Frank-Starling world, the length-tension relationship never sort of fails to generate at least some tension and generate as much tension as it was already generating beforehand. Okay. So you guys mentioned inotropes, and we've had a lot of, there's some thought that dobutamine is really good. So dobutamine is a beta-1 agonist. Half-life is short. It's inactivated in the tissues, partly also by some liver enzymes, and its inactive metabolites are cleared via the kidney. So what do you like about dobutamine? Or what do you not like about dobutamine? Anyone? It's arrhythmogenic. Okay. Causes, can cause hypotension. Why does it cause hypotension? Correct. Yeah, weak, but it's there. Okay.
I rarely ever see it actually.
Thank you, Carrie.
impact.
We never see that.
Yep.
So we never ever see that. Isoproterenol, sometimes you can see it more with that because it's a non-selective beta blocker.
Mm-hmm.
But we almost never see it, and probably when people saw it more is when they used to bolus. They used to bolus dobutamine, they used to bolus milrinone, which can cause hypotension. We almost never see hypotension from these drugs. That's not to say if you don't see it, you shouldn't stop the drug if you think that's what's causing the problem, but don't let that drive your decision, okay? And how about milrinone? So milrinone just allows you to kind of retain calcium in your smooth muscles, which causes vasodilation. Half-life is much longer, and it also is metabolized by the kidneys, so you have to be careful with using it in renal dysfunction. But it just means, that's not to say you should not use it, but you probably just need to give a lower dose than you would to someone with normal renal function, okay? It's actually thought that milrinone might have more arrhythmogenicity when used over the long term, like in outpatients. But it is also can cause arrhythmias, as much as dobutamine in some cases. What it does get you, though, is a little bit more vasodilation, both of the pulmonary circuit and of your systemic circuit, okay? So which of these drugs would you rather kind of go for first if you're in the ER and you're the only one down there and the nurse is like, hey, can we do something here? Okay. Yeah, so I think in general that is the right answer, that when the patient's hypotensive and appears to be poorly perfused, you can usually reach for dobutamine, and 9 out of 10 times you're going to do just fine, okay? And what is your starting dose for dobutamine?
1 microcubic.
That's very conservative, but yes, so 1 or 2, 2.5 where I came from, but somewhere in the 1 to 2 range. And then you should see effects of it within about 15 minutes. You should see the full effect, if not a shorter amount of time. So you can go up after that. All right. How about dopamine? Do we like dopamine for heart failure patients?
Some centers still use dopamine.
Yes, they do.
But we're not
Yeah.
a center that uses a lot of dopamine.
Yeah. So why do you think that is? What is the thought process behind that?
It's not as clean of a drug.
Exactly. I think that's the best answer. So what do you mean, Carrie?
Well, it's got like 3 mechanisms
Mhm.
depending on what dose you use. You could
Right.
dilate your mesenterics, or you can, well, not but, and then you start moving into more of the beta effects, and then you start moving into more of the alpha effects. But it's not very clean in that there's not
Right.
like a clean
Yeah.
assessment.
Right. So when you get called to do a consult in the MICU, and there's like norepi, dopamine, and dobutamine going, it's kind of unclear sort of what is causing what effect, if there's adverse effects to be dealt with, and it's just really unclear, I think. And as you go up on dopamine, you get more inotropic support, but you also get more afterload, which is not good, right? So it releases norepinephrine from the synapses, and you can end up with hypertension, which is one of its good effects, right? I would say, I would reach for this if they told me it's going to take 10 minutes to get a dobutamine drip up here, and we have dopamine right here in the crash cart or whatever. You might use it in the short term to temporize while you get some better, less dirty drug up to handle the situation, okay? All right. Okay, so another pressure volume loop. So you can only really understand pressure volume loops, right, if you have 2. So we'll put the other one up here. So to finish, just to be academic about it, what has happened in this pressure volume loop between the yellow curve and then the yellow loop and the white loop?
Volume increase.
Which volume? So where is stroke volume on this thing? Is it the area of this whole, here, let's go. Is it this whole area? Where is stroke volume represented here? So here's our volume. And when we go in systole from this point, which is where the aortic valve opens and you begin ejecting, over here, that's your stroke volume. Okay? Easy, right? You went from this volume to that volume. So that's your stroke volume. So what happened there? And they're offset just so you can see them on the right side. What happened to stroke volume here? While everything else remained the same. Yeah, so what did we do? Gave an inotrope, yes. So, you ever get challenged with a loop on rounds, which usually doesn't happen, but just during these lectures? All right, so back to stroke volume and heart rate, okay? How about vasodilators? How can vasodilators help us with this cardiac output problem that we are having up in the CCU.
SVRs, cardiogenic shock.
Sure. And why does high SVR create problems for the heart?
More work potentially for the heart.
Yeah. So either more work, more energy is consumed by the heart to get out the same stroke volume, or if you have a failing heart, you just don't get as much volume out of your ventricle. You don't eject as much. So stroke volume actually goes down, okay? And the two things we have readily available are sodium nitroprusside, which takes a while to get up from the pharmacy, as you'll find out. There's usually not emergencies surrounding sodium nitroprusside on our services. We generally don't see hypertensive emergencies and these types of things, but it does take a while to get. And secondly, what you can get very quickly is a nitro drip, just a plain old nitro drip, and for that matter, sublingual nitroglycerin, nitro spray, nitro paste, any of those things are effectively equivalent. You have a little more control, obviously, with a drip than with a paste or something. But sodium nitroprusside, has more of a has both veno and arterial dilating effects. More arterial probably than venous effects, and nitroglycerin's the opposite, more of a venodilator than an arterial dilator, but at higher doses. It also does begin to dilate up the arteries. They both share a common mechanism of action, which is converting GMP into cyclic AMP and vasodilating through provision of NO. Okay. So, and to demonstrate what that looks like in our loops, let's say we're at the yellow loop to begin with, and we then go to the white loop. What has happened here? First of all, what happened to stroke volume? Yeah, so our stroke volume decreased. And what happened to where our aortic valve opened? At what pressure is it opening now? Higher pressure, right? So stroke volume's decreased, aortic pressure's higher. What must have happened? Afterload increase, right? So you can interpret it the exact opposite way. Let's say white is normal, and we gave nitroprusside or nitroglycerin, we can go to the yellow loop, okay? And then stroke volume is increased, and we're happy, because we've increased cardiac output once again, okay? All right, can anyone think of a group of patients who you don't want to challenge with afterload, and who you don't want to challenge with inotropes? And inotropes also increase your metabolic demand, right? So they are causing more energy consumption. So can you guys think of a group of patients who aren't really in a position to consume more energy? AI is, yeah, I mean, those are good ones. But who is suffering from an acute injury to their heart who can't? Yeah, so in myocardial infarction, if you have a patient who has heart failure following an MI, the perfect drug to give is really nitroglycerin or sodium nitroprusside, because you're not increasing myocardial oxygen demand. You're decreasing wall tension because you're opening the aortic valve at a lower pressure. And these are all good things that you can get essentially free cardiac output just by vasodilating them. Okay? So when you hear, post-MI, hypotension, trouble breathing, don't think dobutamine, which is our go-to drug in many situations, but not this one. Think of vasodilators and trying to get free stroke volume without any effort on the part of the patient or their heart. Okay? And we talked about that. Well, we kind of talked about that. But in some of our severe heart failure patients, they will have low blood pressures, right? 80s, 90s. Sometimes we will still start vasodilators because we can still get stroke volume to improve, even though the pressure is really low. And if stroke volume improves, what has to improve? Cardiac output, right? And if cardiac output increases more than systemic vascular resistance goes down, the pressure can either remain the same or even go up on some of these vasodilator drugs, okay? So sometimes we'll do that when we're really in a rock and a hard place, and that's good fun. All right. Nitroglycerin, can be given by peripheral IV. And I didn't say this, but I love our nurses, but sometimes they'll really get on your case about like giving things through a peripheral IV. Dobutamine can be given by a peripheral IV for short amounts of time. Nitroglycerine can also be given via peripheral IV for long amounts of time. So if you have a heart failure patient, you want to treat them, you want to start now and not 6 hours from now when a PICC line has been placed or they finally get their Swan in. Remember, don't let the nurses convince you that these drugs cannot be given via peripheral IVs, okay? All right. So getting back to some of the goals of what we're doing, especially with the vasodilators, do we want patients to have a high blood pressure or something else? You guys come to me and say, Todd, I got the pressure up to 150. Mr. Jones, whose EF is 10%. What am I going to say? Yeah, say it louder.
You want to know how well he's perfusing?
Yeah, so outstanding. Is he still alive or, so you have to be careful in these patients. We, on our service, I think this is how we differ, how the heart failure doctors differ from everybody else. So we are not looking for pressure, okay? We are kind of looking to get rid of pressure because pressure is kind of the enemy of what we're trying to accomplish, which is flow. Now there are some organs like the brain and the kidneys that like pressure, but we, in our experience, have generally seen that they seem to like flow even better. So hypoperfused kidneys tend to do better than hypertensive kidneys, for example, or tend to do worse than hypertensive kidneys. All right? And just some numbers around that. So there is this is like a correlation coefficient is 0.05. 1 means there's perfect correlation. -1 means a perfect negative correlation, and 0 means no correlation. So there's no correlation between mean arterial pressure and cardiac index, almost, 0.05, 5%, let's say, or 2.5%, if you're a real statistics geek like myself. And again, afterload is sort of our enemy with the heart failure patients, okay? We're trying to do everything we can to get their afterload down to improve perfusion, okay? And diagrammatically here, this is stroke volume, right, in the corner, sick patient, not doing well. And all this, don't paint yourself into a corner with afterload, okay? And this is not just a cute drawing, but we see this time and time again. We come and some service that we work closely with will say, yeah, we have them on norepi and dopamine, and the pressure is 90 and their SVO2 is 27%, and they're not perfusing at all, okay? And then there's not much we can do because if they're still hypotensive, it's hard to justify going down on some of these things, all right? Okay, lastly, just a short plug for, half of our whole equation here is heart rate, right? So don't be shy about trying to improve your patient's heart rate. Sometimes patients are toxic on beta blockers, give them glucagon. A lot of our patients are going to have pacemakers. When you see a patient with a balloon pump and like 5 drips and heart rate of 60, go get the EP guys and we'll turn the heart rate up to 95 or 100 and improve cardiac output. Again, it's going to increase myocardial oxygen consumption, but it's kind of a freebie, right? We didn't have to give toxic drugs or really do anything. We're just going to go faster with the heart rate and solve some of these problems, okay? All right. So here we are. So we've done everything medically we can with that equation that we had, pretty much, okay? And still we have the patient here not doing well. So when you've used all these things, all these medications, you've paced them, you've done everything, what do you guys go for next? The consult? It's Saturday, okay? There's no one around. It's just you, Todd. What are you going to request next? There's a Swan in there. Not that that matters here. Does it matter if they have a Swan? Probably not, right? Like if you're doing all this and you had any clue of what you're doing, you're probably doing the right thing. So, next we go to mechanical support, okay? So balloon pumps, all right? Now balloon pumps are kind of like vasodilators. They're kind of like another freebie, except you have to deal with all the complications of having a device in the aorta, okay? But we can get about a 20%.
Nothing is free.
Nothing is free. All right. But what we use it for, and I don't know where you guys were before. Classically, balloon pumps are used to perfuse the coronary arteries. And then they're used to perfuse the coronary arteries, and they're used to perfuse the coronaries. We do not use them here to really perfuse the coronaries. We get that effect. We're really looking for the afterload reduction. Okay? So when the heart beats in systole, we want it to be beating against less afterload. We've already covered that a number of times, right? And the balloon pump does that for us without having to give more drugs or if you're on maximum drugs, okay? So what we can see are increases in pressure and systolic pressures and about a 20% increase in cardiac outputs. That's pretty good, right? Just for putting in this balloon, we can go way up on our output. And then we have all the other devices. This is a centromag, this is an Impella, and this is a tandem heart. We don't use a lot of tandem hearts anymore. We've kind of, for better or for worse, given over to this Impella idea. Do you guys know what an Impella is? Everyone, not everyone?
We're having Impella training also next week.
Okay, but basically the inflow goes into the left ventricle, the outflow is above the aortic valve, and there's a little tiny impeller right around there that squirts blood up above the valve stays shut and flow is improved and the ventricle is unloaded. Okay? This cannot have an oxygenator. You can't use it if there's a big hole in the heart right here. You can imagine you're sucking blood across from the right atrium. The right ventricle. You can get cyanosis. The tandem heart sucks blood out of the left atrium after going across from the right atrium, and then spins the blood out here in this engine and puts it back up into somewhere in the femoral artery or above the iliac bifurcation. Okay. And then you have your big devices like a centromag, which they're being kind to this patient. It looks a lot more chaotic than this. These are cannulated into the chest usually, so they have to go down to the OR and have that placed by our surgeons. And this is like the HeartMate 2, which is generally more for outpatient use. Okay. One device I don't have up here is ECMO or ECLS. And just to go through a few of these though, why you'd use them, why you wouldn't use them. Tandem heart, really high flow. You have to have an intact RV function, so it's not good for biventricular failure. Impella can be placed fast. I don't know, my experience, it seems to hemolyze a lot and tends to fail. I said it here first. ECLS is good when you need to bypass the right heart, the lungs, and the left heart, or some combination thereof. So like if you have a big VSD in the middle of your heart, you can totally unload the heart, take over all the lung function, do everything with ECLS all at once, okay? Or if you have a failing right heart. And centromag, requires OR placement, can be placed on the left or the right, but only handles either the left or the right. You can put in two and do both. At that point, you probably just use the ECLS though. So that's a brief overview. And the only other thing I would say about this is, kind of go for, when you're thinking about which device to use, go for kind of a big one that makes you a little uncomfortable. Like, oh, that seems like a lot. Because usually by the time you get to that point, the patient's in extremis and they need a lot of support. You don't want to pick like, let's do a balloon pump when you're on, max dose pressors and thousands of other things. You have both right and left heart failure. I mean, you know that the patient's probably going to need ECLS. It's probably better to cannulate it, fix the problem if you can, and decannulate it than to, go stepwise up the food chain and spend thousands of dollars and not support the patient along the way.
How often do your heart patients get ACLS? What's the...
We probably do about one every other month on average. There's not much.
If they get ACLS, they switch services?
Well, right now they usually go to the surgical ICU service,
What, for what?
ECLS.
Oh, yeah. We won't
Yeah.
be doing any ECLS.
But we will think about ECLS.
Yes, we will consider our patients for ECLS.
Is someone speaking after me? All right. I just have a few more things. All right, so getting to the end here. So inotropes are kind of like the first thing you should put on. We kind of went over that. And in my mind, the last thing you take off, right? You don't want to have someone on a balloon pump and off an inotrope. You can't, move that patient to the floor and do other things with them that you can do on a inotrope. So keep your inotrope, get rid of your balloon pump, wean the inotrope off later. Okay. And I will also put a little plug in here for digoxin. You're going to find that every attending has a different approach to digoxin. I'm sorry, there's nothing I can do about it. The evidence shows that it does not harm heart failure patients, and it could possibly help. Just like all the other stuff I've talked about, I can't point to great guidelines that tell us how to use these things. But digoxin does seem to occasionally help get patients off of inotropes, and if you have a failed inotrope wean, you might consider starting digoxin.
Why do you think it, because in the studies it has shown to reduce readmissions and, right?
Yeah.
That's about the only thing it's shown. It won't improve mortality or anything, but why is it,
Yeah.
why preventing readmissions but
Not mortality?
not any of the other?
Well, it has a pretty narrow therapeutic range. So once you're above about 1, I think it's picogram per deciliter on the concentration, outcomes tend to worsen. And below some window, it's probably not doing anything. So there's only a very tight range where it's probably effective between like 0.5 and 0.7, 0.8 in terms of its serum concentration. That's my guess. It's also arrhythmogenic. It's a mild inotrope. It also causes hypertension. So it has many effects and can sometimes be useful. I think we should all raise our hands and agree that it can sometimes be useful. So you will find that attendings will come in and like categorically take it off or categorically put it on. And I apologize, but this will happen. And then lastly, as you're treating these patients, just keep in mind there's kind of like a fine line between what is outpatient therapy for these patients and what is inpatient therapy. So when we say beta blockers, ACE inhibitors are good in heart failure, spironolactone, this is not an ICU patients on balloon pumps with inotropes going, okay? This is like long-term, take it for months before you see the benefit. And we see this a lot, and you will see it. Patients will come who have heart failure, who were given high-dose beta blockers because heart failure is well treated by beta blockers, right? We all know that. But there's a time for it, okay? So don't get, in my opinion, don't get too excited about starting these drugs too soon. You can see big problems, and we have seen big problems with people starting these drugs too early, okay? All right. Do you want me to do some questions, or do you guys have questions?
So just what do you call too early? Days, months?
So I think if you've just weaned off an inotrope, that same day is probably not the day to start a negative inotrope.
Typically they'd wait 2 or 3 days.
2 or 3 days is what I do. Yeah.
Just hold it.
Yeah, and I always, in my practice, I always try to have some sort of afterload reduction on, like hydralazine nitrates or an ACE inhibitor before I start the beta blocker, especially if they're naive to a beta blocker. It can really send them for a loop. And you don't want their heart, with negative inotropy and high afterload. Very bad. So, beta blockers should probably never be your first choice of drug to use to set up their outpatient regimen with.
Unless they're tachycardic or even then would you?
Even then I would be, if they're tachycardic, you better figure out why. And it's probably, in our patients, they're usually tachycardic because that's the only way they can improve their cardiac output. So they have, that patient might actually have a bad problem with cardiac output that you have failed to recognize when you are getting ready to write your dobutamine or your metoprolol order. So be careful about that. If I had a patient with an SVT and I thought they needed rate control, I'd probably give them DIG. I probably wouldn't reach for a beta blocker until I was convinced that their cardiac output was stabilized enough to tolerate that. Okay. So I can either do some cases or not do some, whatever you guys want.
That'd be great.
All right. So I'll just let you guys read this, and then there'll be some options for addressing this problem on the next page. Ready? Okay. So what is your first choice of therapy for this guy who just had a STEMI and was poorly revascularized and isn't doing well? B, everyone? Why? Improves coronary perfusion and yeah, afterload reduction, so you're going to decrease oxygen demand on the heart. So whatever crappy blood flow he has through his arteries, you're going to stabilize that by reducing his afterload and getting that free stroke volume, okay? It's not, as Carrie said, and she's correct, it's not totally free. But the point is you're not going to whip him with dobutamine or milrinone, and you might take him to the cath lab and figure out if he needs to be opened up again. But what you really want to do is probably improve this guy's cardiac output by reducing afterload and secondarily by improving coronary perfusion. All right, good job. Let's do 3 more, I think. Okay. So known heart failure, some symptoms, and a nice blood pressure. So what do you guys want to do for this patient? Oxygen. Place a Swan, dobutamine, nitro, or normal saline.
That's a tricky one. Just because she's already tachycardic, she definitely has pressure available, but
Sure, but why is she tachycardic?
because she's a failure.
Right.
Probably is overall having low output, right? Because of the, I was
Yeah.
guessing that because of the poor extremities and the decreased mental status. So improve
Yeah.
output any way you can. essentially.
It'll probably be okay. And at 2 point, have any of you guys ever run a dobutamine stress test in an echo lab? I mean, what does 2.5 of dobutamine do in the echo lab? Well, I don't know. My experience is it does nothing. Like,
2.5?
no. You know, you're up at 30, you're up at 40,
Oh.
you're giving atropine. You know, 2.5 rarely causes a lot of tachycardia.
That was forgetting my
Yes, but this person is stewed in norepinephrine, right? I mean, their heart failure has bathed their body in epinephrine and norepinephrine, so they're even less likely, I think, to have like a reflex or a tachycardia from the drug, okay? So yeah, I think dobutamine would probably be what I would pick here. I think you just want, you have an underperfused patient who looks poorly. This is like my patient on Monday. So you just want to give some dobutamine, and then once you have increased cardiac output from increased stroke volume, you can try to unload with nitroglycerine and do these other things if you so choose. Okay? Probably not give normal saline bolus. Though. You laugh, but I just want to say that 11% of all heart failure patients are admitted are simultaneously on normal saline infusions and diuretics at the same time. Okay. So,
Here, like,
nationally, it's like a Medicare analysis. So, yeah. All right, this one's kind of long, but
I mean, were they, just out of curiosity, was their criteria like above a certain level? Because many providers do order like saline at 10 as a driver or something, so was that one?
yeah, I mean, a driver I'm not worried about, but
But it was like a real infusion, like at 50 or
they thought,
75 or
they seem
100.
to think so.
Okay. 'Cause
It's
that-
Medicare data. But I would believe this, right? We see this all the time.
Yeah.
Patient was hypotensive, so someone gave fluid. They were more hypotensive, so they gave more fluid.
You breathe and they get intubated.
Yes. And then they end up
And
they end up at the University of Washington. All right. So this guy has, what does this guy have? 58. He's been hospitalized for a while. Has pneumonia. You're diuresing him, giving dobutamine. He's on some BiPAP. Now he's hypotensive with decreased urine output. Increased work of breathing and remains edematous. What do you guys want to do? So you're going to give norepi or vaso. Okay. Anyone else?
go back to.
Mm-hmm. Sure. So in my mind, this is a guy I would at least consider for ECLS. He has biventricular failure. His lungs are not normal. Okay. You're already on 10 of dobutamine. You've been trying to diurese him, and things just are not working. So, this is that situation where you say, what's like the kind of most aggressive thing I can think of that would fix this guy? And then talk yourself down from there. If you think you can get away with something lesser, that's fine. But, a patient with biventricular failure, if it's really severe and they're refractory despite diuresis and inotropes, if you give vasopressin or norepi, you could make the situation worse. You might do that temporarily while you get a ECLS circuit set up, but you would not want to delay, calling our surgical colleagues. All of the successful ECLS situations I've seen were because someone felt the little nagging sensation that things were not going to go well, and they called someone, okay? It's never like we sit around on Thursday morning at the transplant meeting and decide that tomorrow someone's going to get ECLS, okay? That's not how ECLS works. So when you have biventricular failure and intrinsic lung disease, think of ECLS. All right? All right. What's that? No. Something like this just happened here. Mm-hmm. All right. What do you guys want to do? Yeah. Say it's 20%. Is the right heart working? No? How do you know it's not working?
Sorry,
Yeah. So what's the difference between your right atrial pressure and your PA mean? It's like 6, right? That's not very much. That's not very much pressure. We're closer to that Fontan patient where we've hooked the right atrium right up to the pulmonary artery, and pressure from the venous system is the only thing driving blood through, right? The RV is just kind of sitting there, barely giving us any pressure. Okay.
What would you ideally like to see that difference?
So it's a good question. So you have to be careful, right? What do you think? How much work do you think my right ventricle has to do to pressurize blood going through my lungs? Very little, right? Yeah, so very little. But when you have a wedge of 40, it's probably much higher, right? So it's a little bit difficult to interpret. You can calculate something called the right ventricular stroke work index to give you some sense. But when you see PA pressure is less than 30 and the pressures are starting to be within 10 millimeters of mercury of each other, the right atrial pressure and the PA mean, I always think about right heart failure.
A normal mean PA pressure is...
Normal mean PA pressure is probably 15. Yeah. So it can look almost the same in a normal person and a very sick person, but the very sick person is very sick.
She's kind of the same as the last patient. She's got biventricular failure.
Yeah, I agree. Yeah, so she's got biventricular failure. And the other reason we will sometimes use or break out the ECLS is for arrhythmias. So if you have electrically unstable situation, you can get out the ECLS system, unload the heart completely, hopefully, obviate the need for the heart and the lungs, fix your arrhythmia or fix the volume situation, get the patient more compensated, and then wean off the ECLS.
So you don't use impellas that's only for left heart?
Yeah, so we just got recently a right-sided impella,
Okay.
and we have the left-sided impella that we've always had.
But like, you wouldn't use an impella for that one because it's
Yeah, so
a
in,
lot of right heart.
that's
I'm kind of unsure when to...
so you should be unsure because it's confusing because sometimes you can correct things going on the left, and the right will also correct. So that happens. That's a real thing. And that is the main kind of break point between whether you think someone's going to need an ECLS circuit or just left-sided support of some sort, is how confident are you that the right ventricle is going to recover with left-sided support only. Exactly. I don't know that I would put in a right impella, a left impella. I'd probably just put on the ECLS circuit because it's a lot more flow. It completely unloads the heart. I mean, the heart will usually go to a standstill with that in because it's not being loaded at all. So by the Frank Starling idea, that stroke volume becomes low because there's no distensing pressure there.
That's VA,
Yeah, so we do all VA for our patients because we're trying to. Yeah, so we are sucking blood out of some venous structure, whether it be the right ventricle, the right atrium, the IVC, the SVC. We are pressurizing it, we are oxygenating it, and we're putting it back in somewhere to provide pressure throughout the aorta. Okay? But for example, if just your lungs are the problem, you can take out venous blood, oxygenate it, put it back in, have it trickle through the lungs, go to a working left heart, and that working left heart will circulate oxygenated blood. So you can just do VV ECMO.
refractory hypoxemia type stuff.
Yeah, so like the lung transplant service, they are the holders of all things ECMO, and they do all well, not all, but most of what they do is VV ECMO. All right, so there's our summary. Talked about all these things. I did find, if you're interested in these pressure volume loops and so forth, my son does Khan Academy. And his thing was up, and I thought I was typing into Google, and I typed into Khan Academy, pressure volume loops, and there's this huge curriculum on all things called Advanced Circulatory Physiology. It's either Advanced Circulatory or Advanced Cardiovascular Physiology. And it's quite good. There's a physician on there. Because there's not a lot of, he's 6. It is awesome. And so if you ever just want to learn more about this, I would actually recommend that because it nicely goes through and very I was like, what is the end systolic pressure volume relationship? And what does that mean? I watched the video and it's like, oh yeah.
They're all on the cardiology fellow website.
Oh, are they?
Yeah.
Yes, that's a good resource. I can provide you guys some other, there were some references in there, but a lot of this is not like, there's no randomized control trial of dobutamine versus milrinone for cardiogenic shock in the acute phase. And you can say that about anything we just talked about. So I would kind of like understand the drugs and how they work and what their complications are more than I would worry about, it's not an outcomes trial where you're trying to figure out did aspirin keep more people alive at the end of the day or not. It's not the situation we're generally in there. So, all right. Any other questions?